Hi, and welcome to Rad Onc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY 5 resident at the University of Pittsburgh, and I am very excited to welcome you to the Rad Onc Study Club, which is a subsection of Rad Onc Talks where we actually review different disease sites in a mock oral board style format. We'll be kicking off this series with a mock oral board style discussion, sharing a couple of breast cancer cases. Just some disclaimers before we get into things. So number one, all of the cases that I present here are completely fictional cases that I have made up, and so any semblance to specific patients is entirely unintentional. These cases have also been created without any sort of input from ABR examiners, without any recall from past examinees, and I myself have not taken the exam. Any of the answers that are presented here are meant to represent one or more possible ways of answering, but they may not be all-encompassing. So there may be more than one right answer, and I may not be able to capture all of the possible right answers. And then finally, this content really is created for educational purposes, does not constitute medical advice in any way. And as I myself am a trainee, I'm always learning. It's possible that there are errors here. If there are any errors, questions, concerns, please comment and we can have a discussion. And then here are some general tips for taking the oral board exam, which I have learned from other colleagues, and also kind of how I envision this resource being utilized for folks that are studying for the oral boards, myself included. So when we're taking the oral board exam, what I've always been taught is the goal is to try to get through as many cases as possible. We're given about 25 to 30 minutes to get through cases, and it serves us better to try to get through more cases because the more cases we get through, the more opportunity we have to demonstrate what we know. And just to give an example, if you say you fail one of the cases that you're presented, well, if you only got through 2 cases and you failed one of them, that looks worse than if you failed 1 case but got through 5 of them. 4 of them, 4 out of 5, if you got right, I think the examiner can feel more confident in converting you to a pass rather than a fail. So the goal is to get through as many cases as possible. And so as a result, it behooves us to kind of answer questions quickly, concisely, and not offer more information than is needed. Try to give short, concise answers. And if the examiner wants to probe and seek more detail, at that point you can consider, offering more information. It is good to kind of be decisive and give concrete answers. And, even if a range of acceptable options exists, it's good to kind of say, this is what I would do. And then if the examiner asks, you can acknowledge that there are alternate options. But generally, on the first go, you want to try to be as decisive and give concrete answers. And it helps to sometimes have a script in mind for how to answer, say, the first workup that you would do for a patient with, a lump in the breast, for example. It helps to have a script so that you can kind of work through things quickly. And then finally, if you don't know something, it's probably better to be honest and admit that rather than make things up and potentially do something dangerous. So those are some general tips for taking oral boards. In terms of how I envision this resource being utilized, I always feel like I learn more when I am being asked something by a teacher rather than just talked at. And so what I'm going to try to do in these videos is to go through a slideshow of case presentations and ask questions and take pauses, and then I'll be answering the question myself, but my hope is that as folks are watching, they can, try to engage during those pauses and try to think of the answer, maybe even say it out loud. And if you need, definitely pause the video and take more time to kind of think of the answer on your own, practice saying it out loud. I'm hoping that this can be, kind of as interactive as a one-woman show can be, but an opportunity for you to kind of take pauses, engage with the video, and have an opportunity to practice answering questions. And the awesome thing about a video like this is that, you can watch these videos while you're completely alone. No one will know if you answered incorrectly, and so now is really the time to make mistakes and learn. And of course, I completely admit that I am learning myself, and it's possible that there may be errors in what I present. And if that's the case, I would love to hear from you so that I can make improvements. So with that, let's get started with our mock oral breast cancer cases. I only have 2 cases for this first video, and we'll try to go through them slowly, much slower than what you would go through on the actual board exams. But my hope is to kind of meticulously go through these cases, address a lot of nitty-gritty details, and make multiple videos just on breast cancer with many different types of breast cancer presentations so that we all become kind of masters of this disease site. And then, my hope is to move on and do that for all the other disease sites as well. So starting with our first case of breast cancer, let's say a 48-year-old woman presents to us with a self-palpated left breast mass. How would you like to work up this patient? It's always good to start with a comprehensive history and physical. In the history, we want to ask about the duration of this breast mass that she's noticed, ask if there's any associated symptoms such as pain, overlying skin changes, and of course, get a complete history. So inquire about any exposure to hormone therapy, her menopausal status, if she's previously ever had breast masses or any other cancers. Also inquire about family and genetic history and if she's ever had any prior radiation before. And then in our physical, we want to perform a complete physical exam focusing on the breast evaluation. So we first evaluate for symmetry and size and shape of the breasts, and then we palpate the bilateral breasts as well as axilla and supraclavicular lymph nodes for any palpable masses or lymphadenopathy. So let's say you perform your history and physical, and on HPI, you find out that she noticed this mass on the outside of her left breast while she was in the shower about 4 to 6 weeks ago. And it's not painful at all. She doesn't have any overlying skin changes, no nipple contracture, no discharge. And her history is fairly unremarkable. So she has a history of asthma, but other than that, no history of cancer or prior radiation. No surgeries. She's G2, P2, both vaginal deliveries, and she's premenopausal. She does have an IUD in place, but she used to take OCPs back in her 20s. So she took oral contraceptives back in her 20s. She does not desire any more children. Her social history, she's not a cigarette smoker. She drinks alcohol socially, 2 to 3 glasses of wine per week. She works as a high school teacher, and there is family history. Her mother had breast cancer at the age of 60. On exam, you palpate a smooth, firm mass on the order of 2 centimeters in the left breast in about the 9 o'clock position on the left breast. You do not palpate any axillary lymphadenopathy. So what workup would you like to order next? So typically when a patient comes in with a palpable breast mass, the first imaging workup that we obtain is a diagnostic mammogram of bilateral breasts. A screening mammogram is really reserved for patients that don't have any palpable abnormalities, but as soon as we definitely know there's something palpable in the breast, we jump to a diagnostic mammogram. So let's say you get a diagnostic mammogram, and these are some images of the left breast. Can you describe what you see? So what we're seeing is 2 standard mammographic views of the left breast. And what we're seeing is that there is a spiculated mass with some diffuse calcifications. So in the left-hand side image, we see a left mediolateral oblique view, and that helps us to see that the mass is located in the upper half of the breast. And then in the right-hand side image, we're seeing a craniocaudal view, and that is showing that the mass is located in the outer quadrant of the breast. So using the information from these 2 different views, we can tell that there is a spiculated mass in the upper outer quadrant of the left breast with diffuse calcifications. Now those 2 views which I just showed, the mediolateral oblique as well as the craniocaudal, those are standard mammographic views that are seen even on a screening mammogram. So what's the difference between a screening mammogram and a diagnostic mammogram, and what additional views are actually offered in a diagnostic mammogram? The additional views that we get from a diagnostic mammogram are magnification views, which allow us to, magnify or zoom in on the abnormality. And the other one is spot compression, which I think is pretty cool because what they can do is they can actually apply a compression paddle to an abnormal appearing area on mammogram. And that helps us to differentiate a mass from just dense breast tissue, with the idea that dense breast tissue will kind of dissolve in the image if there's compression applied to it, whereas a mass would kind of remain present and we would be able to kind of distinguish the mass from dense breast tissue. So we got the diagnostic mammogram, and let's say the reports showed that there was a 2.2 centimeter lesion in the left upper outer quadrant located in the 10 o'clock position, about 3 centimeters from the nipple. What would you like to do next? I think it would be good to get a biopsy of the abnormality seen on diagnostic mammogram. And in terms of the modality for biopsy, ideally we want a core biopsy, right? Because a core biopsy helps us get enough tissue to differentiate between DCIS versus invasive carcinoma, as opposed to just a fine needle aspiration, which would show us carcinomatous cells, but it would not help us to assess the depth of invasion. And then in terms of the technique for core biopsy, if the lesion is visible on ultrasound, we can go for an ultrasound-guided core biopsy. But if it's not able to be seen on ultrasound, then we need a stereotactic core biopsy, which uses mammography to help guide where to stick the needle. So say she's able to get an ultrasound-guided core biopsy, and it shows the following result. So there is invasive mammary carcinoma, Nottingham grade 2, and her immunohistochemistry results show an ER of 90%, PR of 80%, and HER2 new 2+, and her Ki67 is 20%. So based on this pathology, is there any further testing or information that you would like to obtain? I think that pathology report showed us pretty much everything that we would get from a core biopsy. The only thing is that the immunohistochemistry for HER2 new was equivocal. So when we get immunohistochemistry for HER2 new, a 1+ is negative, 2+ is equivocal, and 3+ is positive. So if the HER2 score were 1+ or 3+, we would know what to make of that. But with the 2+ score, it really is equivocal. And so we need further testing with FISH, which is fluorescent in situ hybridization, to actually test for amplification of HER2 new. So let's say the FISH testing was performed and it shows that HER2 new is non-amplified. So she's ER/PR positive and HER2 negative. Is there any additional workup that we need to stage the patient? The last step that I can think of here is to get axillary staging with either an axillary ultrasound and or MRI of the breasts and axilla. What I have typically seen is first starting with an axillary ultrasound and biopsying any nodes that may or may not be suspicious, and then an MRI of the breasts and axilla as well if there's high suspicion. So let's say she gets an axillary ultrasound, which shows a 1.5 centimeter enlarged level 1 axillary lymph node. And this is biopsied, and the biopsy is consistent with a metastatic invasive mammary carcinoma. So how would you stage this patient? She has a 2.2 centimeter primary mass in the left upper outer quadrant, and then she has a 1.5 centimeter enlarged level 1 axillary lymph node. No additional lymph nodes are seen on ultrasound. I would stage this patient as clinical T2N1. So she's T2 because her tumor is greater than 2 centimeters, but less than or equal to 5 centimeters. And then she's N1 because she has a movable ipsilateral level 1 to 2 axillary node. If it were fixed or matted, that would make her N2A. But this, as far as we know, is movable, so it's N1. So T2N1 clinical stage. And then her clinical prognostic stage group is stage 2A. What I have shown in this table is really an anatomic prognostic stage, but in the NCCN guidelines, they say that the anatomic prognostic stage group should really only be used in areas of the world where molecular testing is not available. And when we do have molecular testing, there is a different clinical prognostic stage group that accounts for not only the TNM stage, but also the tumor grade, and then the ER, PR, and HER2 receptor status. So because she's estrogen positive, progesterone positive, and then HER2 negative, and grade 2, that puts her as a stage 2A for clinical prognostic stage group. So what do you recommend for management of this patient? And do you think she would be a candidate for neoadjuvant therapy? Would you recommend neoadjuvant therapy? And if so, which agents would you think about? I want to take a step back and point out that this patient should have genetic testing as part of her workup because she is a woman less than or equal to 50 years old. She's 48 years old. Other criteria besides age for genetic testing include triple negative breast cancer, having multiple primary breast cancers, lobular histology, as well as personal history of gastric cancer, and then having one or more family members that were diagnosed younger than age 50. So based on her age, she is a candidate for genetic testing, so that should be done at some point. And then to answer the question about neoadjuvant chemotherapy, I do think institutional practices might vary, but at my institution, I think she might have gotten neoadjuvant chemotherapy. She's a premenopausal patient. She has clinical T2N1 disease, and the benefit of giving neoadjuvant chemotherapy in this patient is that if her axillary disease converts to a clinically node-negative disease, then she could potentially omit an axillary dissection and get sentinel lymph node biopsy. So neoadjuvant therapy is an option for this patient. And in terms of the regimen that we would do, typically for patients that have node-positive disease, that are hormone-positive, HER2 negative, the standard therapy is ACT. So that's adriamycin and cyclophosphamide given for 4 cycles, which is 8 weeks total, and then weekly paclitaxel for 12 cycles, which is 12 weeks total. So ACT, adriamycin, cyclophosphamide, followed by paclitaxel. So let's say she completes chemotherapy and has a restaging MRI, which shows a good response, and she has a clinical complete response in the axilla. She then goes for breast-conserving surgery with sentinel lymph node biopsy, and her pathology shows the following. So on the lumpectomy specimen, there are 2 foci of invasive carcinoma, one measuring 0.2 centimeters and the other measuring 0.5 centimeters, and these are in a background of a 2.5 centimeter area of fibrosis. It is graded as Nottingham grade 3. And then her ER is still 90%, PR 80%, HER2 new is 2+ and negative on FISH, just as in her previous biopsy. And then her Ki67 is 15%. She also has a sentinel lymph node biopsy, and a total of 3 nodes are sampled, of which 2 are positive for disease. So is there anything else that you would like to know from her pathology report? The one thing that I think this pathology report was missing is the margin status. So we really need to know if the cancer extends up until the margins or if the margins are negative. And do you remember what qualifies as negative margins for invasive ductal carcinoma? So it's no tumor on ink. For DCIS, we want to have margins that are at least 2 millimeters clear to be considered clear margins. But for invasive ductal cancer, no tumor on ink is good enough to call it clear or negative margins. So she has negative margins. The next question I have is, what if the margins were positive? What would be your next step in management? If the margins were positive, we would have to go back to the surgeon and ask them to re-excise the positive margin because no amount of radiation makes up for a positive margin. So that's the answer. If there's positive margins, you have to ask the surgeon to go back and re-excise. Fortunately, in this case, the margins were negative. So what is this patient's stage post-operatively? So she's clinical T2N1, and then post-operatively we say YP to indicate that this is a pathologic stage after having received some sort of neoadjuvant therapy. So she is YP T1A because her tumor foci were less than or equal to 0.5 centimeters, YPT1A, and then N1A because she had 1 to 3 positive axillary nodes. So she's CT2N1, YPT1A, N1A. Now, how would you like to manage this patient? Would you offer her any adjuvant therapy? So that's a loaded question, but yes, she would definitely benefit from adjuvant therapy. From a radiation perspective, I think she would be offered whole breast radiation as well as comprehensive regional nodal irradiation, followed by a lumpectomy boost, given that she had high grade as well as young age. The reason for adjuvant radiation, the indication in this case, is that she had node positive disease. She had a lumpectomy. So given her age, she would undoubtedly benefit from postoperative radiation after the lumpectomy alone. And in this case, she had even higher risk factors since she had node positive disease and she had an incomplete response to neoadjuvant chemotherapy. So because of this, we would offer her whole breast and regional nodal irradiation. I think the other alternative for her is to get completion axillary dissection. And I know that this is a question that's being studied in the ongoing Alliance, I think it's A11202 trial or A011202 Alliance trial. And this trial is kind of like the Amoros trial, but in the context of neoadjuvant chemotherapy. But, she's going to need adjuvant radiation anyways for her breast. And so it might make sense to just offer her regional nodal irradiation and spare her the increased chance of lymphedema if she were to get a completion lymph node dissection. So I would probably offer this patient whole breast radiation with regional nodal irradiation, and I would give her a lumpectomy boost, again, given that she had high-grade disease and young age. And then in terms of beginning the radiotherapy, ideally would begin about 4 to 6 weeks after surgery, after she has had time to heal. And then in addition to adjuvant radiation, she does need adjuvant systemic therapy as well. So since she had an incomplete response, she would probably get adjuvant abemaciclib for 2 years. That is a CDK4/6 inhibitor. And then she would also get adjuvant endocrine therapy because she was ERPR positive. And since she's premenopausal, that endocrine therapy would probably be tamoxifen, 20 milligrams daily for 5 years. So let's say that you agree with me and you're going to give this patient whole breast plus regional nodal irradiation followed by a lumpectomy boost. Can you describe how you would simulate the patient for radiation? So the simulation setup for breast cancer patients is fairly standard. I would simulate this patient supine on a breastboard with her arms raised and chin turned to the contralateral side. I would wire the breast tissue as well as the lumpectomy scar, and I would place wires at my field borders. So medially, I would place a wire inferior to the sternal notch. Superiorly, I would place one at the inferior aspect of the clavicular head. My lateral border would be the mid-axillary line, and then inferiorly, I would go 2 centimeters beneath the inframammary fold. And I would place the isocenter on a free-breathing scan, but then I would make her do a deep inspiratory breath hold for my planning scan. And this would help to expand her lungs and push the heart away from the chest wall, especially since we're going to be treating regional nodes as well. I think deep inspiratory breath hold technique should be taken advantage of. So let's say we scan her and we are now planning her radiation. Can you please describe the dose, target, and technique that you would use? So for dose, I would use moderately hypofractionated radiotherapy, something like 40 gray and 15 fractions, like in the UK START B trial, or the other option is 42.56 gray and 16 fractions, as in the Canadian trial. And then for the boost, can deliver 10 gray and 4 fractions, or 12.5 gray and 5 fractions, or even 10 gray and 5 fractions. The initial target would be the whole breast and regional lymph nodes. So the regional nodes, I would cover axillary levels 1 to 3, the supraclavicular nodes, as well as the internal mammary lymph nodes. And then for the boost volume, I would just cover the lumpectomy cavity. And in terms of technique, I would do 3D conventional radiotherapy using opposed tangents for treating the breast volume and the axilla. And then for the supraclavicular field, we need to set a separate AP field at a slightly oblique angle, targeted away, kind of angled away from the esophagus and the spinal cord. And then in terms of the boost, this can be done either with an electron field where we treat the lumpectomy cavity with a 2 centimeter block margin, or can treat the lumpectomy cavity using photons with mini tangents. The other option for dose and technique, if we're not using 3D conformal radiotherapy, is to actually use IMRT and do a simultaneous integrated boost, 40 gray and 15 fractions, with a 48 gray simultaneous integrated boost to the lumpectomy cavity. But I know that in reality, there's often difficulty approving IMRT through insurance. So whatever technique you're going to describe, I would feel comfortable describing the technique that you're using, as well as dose constraints for the dose fractionation that you're using. So for me, I would probably just say 40 gray and 15 fractions, followed by a 10 gray and 5 fraction boost. And I would plan to use 3D conformal radiation. So on boards, it's possible they might ask you to actually draw out some volumes, including a lumpectomy GTV or a CTV for your chest wall, or one of your lymph node spaces. I'm going to kind of skip that part for now. And let's say we, submit our contours, submit our prescription, and we get a plan back from dosimetry. Can you describe how you would evaluate the plan? I always use the CB CHOP mnemonic to mentally check off all of the steps of evaluating a plan. So that is check your contours, beams, coverage, hotspots, organs at risk, and your prescription dose as well. In reality, I usually check the prescription dose first to make sure it's exactly what I prescribed. Double check the accuracy of contours, including targets as well as organs at risk. And then for beams, you want to check the beams and make sure that your beams aren't going through the contralateral breast. Make sure that they are accurately blocking the heart and not treating unnecessary heart. And then for your coverage, you want to evaluate your PTV eval. So typically we make a PTV eval that is cropped 3 to 5 millimeters inward from the body contour. So when we design our beams, we typically plan them with flash to account for any swelling in the breast and things like that. So that means that our beam is a little bit wider than the edge of the breast. But then when we're evaluating, we actually evaluate the PTV eval, which is cropped inward from the skin, because we understand how photons work and understand that we're not going to get skin dose unless we are intentionally putting bolus to cover the skin. So we evaluate the PTV eval, and ideally at least 95% of the PTV eval should get 95% of the dose. So we call that 95-95 coverage, where at least 95% of your volume is treated with 95% of the dose. And then for nodal volumes, we can accept a little bit less coverage, so 90-90 coverage. It's harder to get better than that with 3D planning. And then your lumpectomy PTV eval should ideally have at least 95% of the lumpectomy volume getting 100% of the coverage. So we look for, covering that a little bit more robustly. So 95-95 for the whole breast, 90-90 for the nodal volumes, and then 9500 for the lumpectomy PTV eval in terms of your coverage. And then we also look at heterogeneity and hotspots. So Some of the hot spots that we try to limit, we try to keep our volume receiving 110% of the dose to be zero. So we want no 110% hotspot. We try to keep our volume receiving 107% of the dose to be less than 5%, so V107 less than 5%, and then V105 less than 10%. So 110 is 0, 107 is less than 5%, and 105 is less than 10% for our hotspots. And this is for 40 gray and 15 fractions, or even 42.56 gray and 16 fractions, moderately hypofractionated radiation. So that was a lot, the first half of CB CHOP. Moving on to that final part of organs at risk, can you think about some of the dose constraints that you would utilize for a 15 or 16 fraction radiotherapy plan for breast? So some general constraints that we use for moderately hypofractionated breast radiation, we try to keep the heart mean dose less than 2 gray and really no more than 4 gray. The ipsilateral lung, we try to keep the volume getting 20 gray, less than or equal to 35% maximum at most. Ideally, we would be less than that, somewhere between 10 to 20%. But when we're doing regional nodal irradiation, that number is going to go a little bit higher, and more of the ipsilateral lung is going to get V20 gray. So V20 less than 35% max. The contralateral lung, we try to keep the V5 gray less than 10% max. Contralateral breast, V3 gray less than 5%. And then LAD is something that we can constrain as well, based on a paper. The first author is Dr. Zurich on that paper. And the mean dose can be 5 gray, the max can be 10 gray for the LAD. And that's just kind of adapting from the EQD2 that came in that paper. So these are some general dose constraints, and it's probably good to go into boards with some dose constraints memorized for every disease site. Just for reference here, I have a table from my dose constraints notes these are modified from the UK Start B protocol. So these include some additional organs that we can think about when we're doing regional nodal irradiation, such as the spinal cord, as well as the esophagus. But what I kind of listed off in the previous slide, I think, are some reasonable dose constraints that you could cite in boards. So let's say this patient starts coming in for treatment, she's tolerating radiation relatively well, and then in her last week, she complains of redness and itchiness over her breast. And on exam, she has this red acneiform rash that's kind of concentrated more in the axilla and the inframammary fold. It's darker there, but it's kind of diffuse over her entire breast. But you examine her and you don't see any evidence of moist desquamation. So how would you grade this skin toxicity, and how would you like to manage? I'm sorry I don't have a good picture of this, but based on the description, it sounds like it's grade 1 dermatitis. Grade 2 is if she would have some moist desquamation kind of in her skin folds, and then grade 3 would be if she had moist desquamation kind of diffusely over her breast. But based on this description, it sounds like grade 1 dermatitis. And, we typically counsel patients on expected skin toxicity prior to them even starting treatment. And we give them skincare instructions during radiation. So she should have already been instructed to apply Aquaphor or some other type of unscented lotion twice daily to her radiated breast and armpit area. And then when patients come in with itchiness from radiation treatment, dermatitis, we can actually prescribe steroid cream, which tends to be helpful for that. And some folks actually might consider prescribing prophylactic steroid cream. There's data for applying mometasone furoate 0.1% topical cream once daily as kind of a prophylactic measure to mitigate dermatitis. So She gets steroid cream, her breast heals up, and she does better. You see her at 1 month follow-up just to check in on her toxicities. How would you counsel this patient about her oncologic follow-up? I would probably say something like obtain an H&P every 6 months for the first 2 years and then annually thereafter, and then complete an annual diagnostic mammogram starting about 6 months after radiation. And if you look at the NCCN guidelines, they recommend an H&P 1 to 4 times per year for the first 5 years and then annually thereafter. And they recommend having an annual diagnostic mammogram starting 6 to 12 months after radiation. And then they do say also that routine imaging of reconstructed breasts is not indicated. So that wraps up case one. And what I'd like to do now is move on to a second case, and we'll kind of gloss over some of the more like diagnostic workup type things and focus mostly on the management for this one. So case two is a 74-year-old woman who has otherwise excellent performance status, and let's say she undergoes a right-sided breast-conserving surgery for a clinical T1b N0, pathologic T1b N0, ERPR positive, HER2 negative invasive ductal carcinoma. She has negative margins. They're clear by more than 2 centimeters. They're clear by more than 2 millimeters. And she has grade 2 disease. And her molecular results show an ER of 80%, PR of 70%, HER2 neu 1 plus, so it's negative, and Ki67 of 16%. So a pathologic T1 N0 ERPR positive HER2 negative invasive ductal carcinoma, status post breast conserving surgery, and she's 74 years old. Let's say that she spoke with her medical oncologist about adjuvant endocrine therapy, and she is considering avoiding radiation therapy, but she still comes to you because the medical oncologist scheduled this appointment. So how would you counsel her about avoiding radiation? So my short answer to this question is that I think we have enough data to say that we know that adjuvant radiation after breast conserving surgery does not improve survival, but it does offer a local control benefit. And even for these lower risk breast cancer patients, based on the PRIME 2 and CALGB 9343 study, the risk of a local recurrence with the risk of an ipsilateral breast tumor recurrence with surgery alone was about 10%. And it was reduced to about 2% with the addition of radiation. And keep in mind, all of these patients still got endocrine therapy for 5 years. So if we just do surgery and 5 years of endocrine therapy, the risk of ipsilateral breast tumor recurrence is about 10%. And if we add radiation to that, we can drive it down to about 1 to 2%. Now, some folks think that these trials may have been kind of too inclusive, and if we kind of narrow down our criteria, there are subsets of even lower risk patients that perhaps we can avoid radiation therapy. And that's probably true. So there's the Lumina study that looked at patients that were 55 or older with a luminal A phenotype. They had to have a tumor less than or equal to 2 centimeters and a Ki67 less than 13.25%. These patients had an extremely low 5-year rate of ipsilateral breast tumor recurrence with endocrine therapy alone after surgery, and that risk was 2.3% compared to a 1.9% risk of recurrence in their contralateral breast. So it was the same on both sides, right? Which means that with endocrine therapy alone, these patients are probably, fine. There was also the IDEA study that looked at patients ages 50 to 69, ERPR positive, HER2 negative, who had a low oncotype score of less than or equal to 18, and they had a 99% freedom from 5-year local recurrence as well, with omission of radiation. But all of these patients that omit radiation still get treated with adjuvant endocrine therapy. And there is an ongoing study, the Europa study, which is randomizing patients to 5 years of endocrine therapy versus only 5 days of radiation. And so far, the health-related quality of life outcomes have been reported, which showed improved quality of life in the patients that got radiation. So, long story short, it's difficult to predict exactly what her risk of ipsilateral breast tumor recurrence is, and chances are it's fairly low in the single digits. But we also know she would not have qualified for the Lumina study based on her Ki-67. But based on the data that we have, it does seem that radiation definitely offers a local control benefit. And in the modern era, we can treat her in as few as 5 days. So she might as well get treated for 5 days. And if something happens where she's not able to tolerate her endocrine therapy, at least we can rest assured that we've given radiation. So let's say that after talking with you and hearing what you have to say about radiation, she is more interested in hearing about this 5-fraction radiation. We can get radiation done in just 5 days. We know that there are 2 different 5-fraction regimens, right? There is UK Fast Forward, which treated the entire breast to 26 gray in 5 fractions in 1 week. And then we also have accelerated partial breast irradiation, where we can give 30 gray in 5 fractions either every other day or consecutively over just 1 week. How would you decide between APBI or whole breast radiation? And who is a candidate for APBI? So the criteria I have listed here for accelerated partial breast irradiation are from the ASTRO guidelines from 2023. There are other guidelines as well, such as the ABS guidelines, but based on the ASTRO guidelines, patients that are 40 years or older, have a tumor size of 2 centimeters or less, and grade 1 to 2, as well as ER-positive histology, are suitable for APBI. There are some cautionary criteria, so size of 2 to 3 centimeters, grade 3 disease, ER-negative histology. These are situations where APBI is conditionally recommended. And then other cautionary criteria are lobular histology, LVSI, or HER2-positive disease not receiving HER2-directed treatment. These are areas where APBI is conditionally not recommended. And then finally, unsuitable for APBI are patients that are younger than 40 years old, if they have positive margins, if they have positive lymph nodes, or if they have BRCA1 or 2 mutation. So age less than 40, positive margins, positive lymph nodes, and BRCA1 or 2 mutations are kind of your absolute contraindications for APBI. So we definitely consider suitability for APBI when we're evaluating whether or not we would treat a patient with this. And then the other kind of practical thing that we need to think about is sort of the lumpectomy cavity to breast volume. So if it's a very small breasted patient and the lumpectomy cavity looks like it's kind of taking up more than a quarter of the breast, and we don't think that we can meet some of our dose constraints for the ipsilateral breast with APBI, then we might as well offer whole breast irradiation. But for patients that are larger breasted or who have a smaller kind of lumpectomy to breast size ratio, we can think about offering APBI. So the patient decides to pursue adjuvant radiation, and she is a candidate for APBI. So can you describe your dose, target, and technique for accelerated partial breast irradiation? So accelerated breast irradiation, the dose is 30 gray in 5 fractions, and this can be given daily or every other day. I would probably give it every other day. The target is your lumpectomy cavity with an additional 1.5 centimeter CTV margin. And then a 3 to 5 millimeter PTV margin. On the Florence trial, I believe they did a 1 centimeter CTV margin cropped out of barriers to spread, and then they added another 1 centimeter PTV margin. At my institution, we've been doing 1.5 centimeter CTV and then 3 to 5 millimeter PTV margin. And the technique is IMRT, and we use daily cone beam CT for image guidance. And I forgot to talk about image guidance in case 1, but for a 3D treatment, I would probably do daily MVs. And then for this case, I would just do daily cone beam CT. And then in terms of dose constraints, what dose constraints would you use for evaluating a plan? So with APBI, we actually limit the hotspot even more than we do for whole breast irradiation. So the PTV 105% should be 0. So we want no hotspots greater than 105% for APBI. Other dose constraints, we limit the dose to the uninvolved breast. So that's your breast minus your PTV eval. So we try to keep the V15 gray, so 15 gray is 50% of the dose. We try to keep the V15 gray less than 50%. So the volume receiving 50% of your prescription dose should ideally be less than 50%. And actually 50% is the upper limit. Ideally, we would like it to be less than 25%. So V15 gray less than 25% or 50% at most. The maximum dose to the contralateral breast should be less than 2 gray. For your ipsilateral lung, the volume receiving 10 gray or more should be less than 20%. And then the contralateral lung, the V5 gray should be less than 10%. So V10 less than 20 for the ipsilateral lung, V5 less than 10 for the contralateral lung. Heart, V3 gray less than 10%. So just to reiterate all of these, your uninvolved breast is V15 gray, less than 50% at most, ideally less than 25%. Contralateral breast max is less than 2 gray. Your ipsilateral lung V10 is less than 20%, and your contralateral lung V5 is less than 10%, and then your heart V3 is less than 10%. And these are just the same dose constraints laid out in a table format. So that brings us to the end of our very first mock oral board style case review. And again, I thank you so much if you listened to this whole video. I hope that it was helpful for you, and I hope that this question answer format kind of helped make it a little bit more engaging, and hopefully you were able to participate and try to answer some of the questions. Huge caveats. Again, I have not taken the oral boards yet, so I don't know that this experience 100% replicates what you would see on oral boards. It definitely doesn't, because I think oral boards are more interactive. They have you actually draw things out, look at DVHs, things like that, which I'm probably not going to be able to do on this format. But, hopefully it's at least a start. We definitely went through cases a lot slower than we would have in actual board exams. But my hope with just going through them very slowly and meticulously is to, reinforce some important points now so that when you're actually in boards, they come very quickly and you can kind of gloss past them. Finally, if there's any mistakes in this, I apologize. I would love to hear from you if there are so that I can make improvements. I recognize that some of the cases, especially that first case, it might be a little bit controversial as to how to manage that. I do think that the treatment path that I kind of went down was one acceptable way, but there's probably other acceptable ways to kind of treat that same patient as well. So if your thoughts didn't completely align with mine, especially for that first case, I definitely think that there's room for alternate pathways there. So that is all. I definitely hope to make several more breast cancer videos just like this one, going through other nuances and different types of cancers. We didn't even touch on triple negative or HER2 positive breast cancer here. So there's actually a lot to kind of cover. And I hope to do this for other disease sites as well. So if you watch this, I would love some feedback on the structure, what worked, what didn't. And I hope to make more videos just like this. Thank you if you've joined the Rad Onc Study Club. I really appreciate your support. And I hope to see you back in future videos. Thank you so much.